Hello everyone. Good evening. Can you all hear me clearly? Hello, hello. Can someone type in the group chat if I'm clear? Hello. Clear po? Alright. Good evening everyone. Ayan. Hi. Welcome to our ano tawag dito? Welcome to our quick fix group study. Hello. I think I recognize some of the names here. Marami dito mga naging students ko. Ayan, nakikita ko yung mga emojis. Hello. Ayan. Miss ko na kayo. Charing. Ano to, naging fan club bigla. Ayan, so hello po, good evening everyone, and welcome to our quick fix group study. So, it's nice to meet some of you, yung mga bago, and yung mga naging students ko na, welcome back to our session, okay? Ayan, so hello po, good evening everyone, and welcome to our quick fix. Okay, anyway, may nag-chat ng mahaba. Okay, anyway, so our discussion tonight will be, sorry, mag-i-introduce nga pala muna ako sa sarili ko, di ba? So, my name is Mentor Abby. Okay, and I am your mentor for tonight. I've been with the Riigapo Service System for around 3 years now, and I've been teaching in most of those 3 years po. So, my specialty under the system is actually on cardiovascular diseases, blood disorders, blood vessel disorders, as well as research, and nursing research. Okay, but for tonight, we will be focusing on something that's related to hematological disorders. To be particular, this is immune thrombocytopenia. Okay? Immune thrombocytopenia, that is now the current name. Hello! Hello mga anak. Ay, nagkaanak pa nga ako. So, immune thrombocytopenia, this is actually the newly recognized name of the old name of the disease, which is idiopathic thrombocytopenic purpura. Okay? So, ang name na ginagamit na po natin ngayon is immune thrombocytopenia. Because when you say idiopathic, it basically means that you don't know what is causing the disease. Okay? But with immune thrombocytopenia, they already found out what is causing this problem. Basically, to summarize, your immune thrombocytopenia, it is an autoimmune disease that is attacking your own platelets. Okay? So this is basically what it looks like. The most famous presentation of immune thrombocytopenia is that these patients get petechiae and purpura. Okay? So they look like rashes on their lower extremities, but that is actually their capillaries and their small blood vessels bursting under the skin. And once again, the cause of that is the low level of platelets in the body. Okay? So immune thrombocytopenia, it is a bleeding disorder characterized by a low level of platelets. Okay? Basically, what happened is your platelets were attacked by your own antibodies. Okay? So what usually triggers these attacks? Having had a recent viral infection, most famous most famous virus that can cause this is your Epstein-Barr virus. Okay? So it can actually present like something like the flu or sore throat. Okay. History of hepatitis C, HIV, and even COVID can even trigger the ITP. Okay. Now, the thing about viral infections is that when our body is trying to overcome these viral infections, okay, it could also trigger an abnormal immune response. So instead of just attacking the virus itself, it could our own immune system could also possibly attack our own body cells. And that's what happened here in ITP. Okay? Other autoimmune diseases could also cause your ITP. For example, if you've heard of the condition known as systemic lupus erythematosus. Okay? So that is an example of an autoimmune disease, and the effect and the complication of that could be ITP. Okay? Rheumatoid arthritis is also related to ITP. Okay? Because rheumatoid arthritis is also an autoimmune problem. Okay? Taking certain medications can also cause your ITP. For example, your anticoagulants like heparin, especially if your patient has been taking this type of anticoagulant for an extended period of time. We could call that heparin-induced thrombocytopenia. Okay? Taking certain anticonvulsants could also trigger ITP. Okay? So it could be drug-related. Okay? So what is the pathophysiology related to your immune thrombocytopenic purpura? Okay? So this is caused by immune dysregulation and autoantibody production. Okay? So once again, this could be triggered by a current autoimmune disorder, could also be triggered by a recent history of viral infection. Okay? Now, this causes a rapid platelet destruction and impaired clearance. Now, if you're going to look into the laboratory studies of this patient with ITP, what you will notice is that they have a low level of platelets, but their coagulation studies, particularly the prothrombin time and the partial thromboplastin time, so the PT and the PTT, they are still normal. Okay? So again, the platelets are normal, platelets are low, but the PT and the PTT are both normal. Okay? Now, this leads to thrombocytopenia. When you say thrombocytopenia, from the word pinya at the end of the sentence, it means that, okay, there is a low level of the blood cell. Okay? So thrombocytopenia, low platelets. Now this will cause petechiae, purpura, and mucosal bleeding. Ma'am, what's the difference between petechiae and purpura? Petechiae they're basically smaller rashes. It's less than 2 millimeters in size. Okay, and it affects the smaller capillaries. Purpura, it's around 2 to 10 millimeters in size. Okay, each individual rash is 2 to 10 millimeters, and this one affects larger blood vessels. Okay, and then after purpura, we now have ecchymosis. Okay, now ecchymosis, that's already a bruise. Okay, so that's over 10 millimeters in size. And these bruises, they look bluish, purple, green, and yellow. Meanwhile, for petechiae and purpura, they just look reddish in appearance. Okay? So that's what it looks like. Now, you might be thinking, how will I know if the rash the patient has, it's related to a bleeding disorder or not? Okay? So, if you try, you can actually do this using a glass test. The glass test. So you take a glass, okay, and then you check, and then you put the glass against the skin of the patient and check if there is blanching. Okay? If there is blanching, meaning the rash is faded after you've put the glass over the skin, then that's just a rash. But if the skin did not blanch, or the rashes did not blanch, they stayed the same, they're still reddish, then that means it is a bleeding lesion. So it could be petechiae or purpura. Okay? So there you go. Now, ITP follows viral infection in children. So like we mentioned, viral infection, right? So in children, the most common viral infection that can affect them is also chickenpox. Okay? Chickenpox can actually ITP can actually follow chickenpox. So it is best to have children vaccinated, okay, at a very young age. Okay? Or rather when they are prescribed to take the vaccine. Okay? Risk factors for ITP. Women are at risk at a younger age, and men are at risk at an older age. Having a history of chickenpox, mumps, and measles can also increase the risk. So as you can see, all of these are viral infections. Okay? Now, symptoms of ITP, okay, you have purple bruises on the skin and mucous membranes inside the mouth, okay, and petechiae. So, this is what petechiae and purpura looks like. So, the smaller lesions, those are your petechiae. The larger lesions, they are more of your purpura. And usually you can see these rashes on the lower extremities of the patient or of the child. Okay? Now, the lesions are not just seen on the lower extremities. You can also see them in the oral mucosa, and this is what it looks like. Okay? Medyo nakakadiri. to be really honest. Yan. So they are black papules, and that is caused by bleeding under the skin of the oral mucosa. Okay? There you go. Now, ITP could either be acute or chronic. So if it's acute, it lasts less than 6 months, and it is more common in children. Okay? Actually, the acute form of ITP, it is more common in children, and it especially occurs after a viral infection. Okay? Then for chronic ITP, this lasts longer than 6 months and it is more common in adults. Teenagers and younger children can also be affected. But chronic ITP is more common in adults. So we can say it's chronic if the condition has lasted already more than 6 months. Okay? I think we already had that slide. Okay, this one. Now, acquired platelet function disorder is due to long-term intake of the following medications. So like I mentioned earlier, it could be related to blood thinners. Okay? Blood thinners like your aspirin, your heparin, your warfarin, especially if you've been taking them for a long period of time. Okay? I'll give you an example where you will probably be taking blood thinners for a long period of time. For example, you are a patient who recently suffered from a myocardial infarction. Okay? Myocardial infarction, that's what you know as your heart attack, right? Now, for the first 12 months after you have suffered an episode of MI, you will be required to take two types of antiplatelet drugs, okay? And that's what we call dual antiplatelet therapy, okay? You will need to take two types of antiplatelet drugs because you do not want another blood clot to form around any fatty plate in your heart because that could trigger another episode of myocardial infarction. Okay? So in that 12 months, that's a long period of time. You need to check the patient every now and then if they are showing signs and symptoms of platelet function disorder like ITP. Okay? Then we have certain heart drugs. Yes, certain heart drugs and antiarrhythmics can also alter the platelet function. Okay? Antidepressants, anesthetics, antihistamine, and of course, aspirin. And as you know, aspirin is an antiplatelet drug. And last but not the least, you have NSAIDs. Okay? NSAIDs like ibuprofen can also alter the platelet function. Okay? Now, in ITP, you will not just see petechiae, purpura, and what do you call this? Lesions inside the oral mucosa. You can also see active forms of bleeding. Okay? So under the skin, that's your petechiae in the lower extremities. Bleeding through the nose or epistaxis, that could also occur. Yan. Bleeding with the urine, so that's your hematuria. Okay? Bleeding through the stool. So this could be either fresh blood in the stool or already dark tarry stools. If it is fresh blood, it means that the bleeding occurred in the lower part of the GI tract. Okay? In the lower part of the GI tract. And if the patient's stool is already black and tarry or dark and tarry, then it means the bleeding, it occurred in the upper gastrointestinal tract. Okay? And as we know, if your patient is already having black tarry stools, you cannot further give, let's say for example, NSAIDs, especially if they haven't eaten just recently. Okay? Okay. So stools, bleeding through the gums can also occur through bleeding through cuts. And for women, excessive bleeding during menstruation. Okay, so you need to take the history of these women and ask them how many pads do you usually consume within the day. And you will notice in this patient with ITP, they will mention that they've been consuming more pads than they regularly would. Okay. Yan. Now, the bleeding complication of ITP is actually intracranial hemorrhage. Okay? Intracranial hemorrhage, this is a life-threatening complication of ITP. Okay, so this could lead to a hemorrhagic stroke. Yeah. But in intracranial hemorrhage, yeah, so you will need to make sure that the patient will not get this type of complication. So of course, we want to ensure that the patient is free from injuries, or let's say we need to limit how they are doing their physical activity. So as much as possible, we advise them not to do contact sports while they still have ITP. Okay? So that we can protect them. ITP actually may not require treatment. So let's say, for example, the trigger of the ITP is let's say the trigger of the ITP is, let's say, a recent viral infection. Okay? Now, this viral infection, once it has completely resolved, okay, the ITP can also resolve on its own. Okay? So, in milder cases of ITP, it may not require treatment, but sometimes we just need supportive therapy. Okay? So, hydration, okay? And, yeah, depends on what the patient needs at the time. Of course, you need to prevent and manage bleeding. Okay. Diagnostics for ITP. So of course, we will need to do our physical examination. So for physical examination, we want to check what parts of the body, okay, is the patient having some form of bleeding. So we check the oral mucosa, we check the lower extremities. We basically check everywhere. Okay. So that's what we do for PE. Now the CBC or complete blood count. Again, what you will notably see in this patient with ITP is that their platelets are low, okay, but their PT and their PTT are both normal, okay? Kidney and liver function tests are also indicated because, okay, both of these are also concerned with formation of your blood cells. Okay, so you will need to check these function tests to evaluate, okay, how it's related to the ITP. And last but not least, you will need a bone marrow test because you might notice that the possible cause of ITP could already be a bone marrow problem. Let's say, for example, in patients with leukemia. Patients with leukemia also develop a low number of platelets because there's too much white blood cells that are crowding within the bone marrow. Okay? So you want to double check if this patient is having a bone marrow problem or not. Okay? There you go. Now for management, okay? For management of ITP, so what we want to do, okay, initially, is that we want to suppress the activity of the immune system because, like we said earlier, it is what's attacking, okay? That's what's attacking your platelets. And the best way we can do that is we give prednisone, okay? So this can increase the platelet count by decreasing the activity of the immune system, okay? And then another drug that we can give as first line is your IV immunoglobulin. Okay? So this one, your IV immunoglobulin or IVIG, basically the purpose of this one is that it confuses your immune system so as not to attack the platelets. Okay? That's basically that's basically the function of your immunoglobulin. So it confuses your macrophages not to attack the platelets, therefore suppressing the destruction of the platelets itself. Okay? And then we can also do antibody therapy with rituximab. Now, rituximab, this one destroys the B cells. Now, the B cells in ITP, they are actually responsible for creating the antibodies that are killing off the platelets. Okay? So that's the purpose of your rituximab. It destroys the B cells that are creating the antibodies that are destroying the platelets. But rituximab is not considered one of the first-line drugs to be given for patients with ITP. Okay? You can only give rituximab if your patient did not respond to steroids and IVIG. Okay? And those are the cases that we call refractory and chronic ITP. Okay? Now, for patients with rituximab, okay, since this attacks your B cells, this can also cause immunosuppression. Okay? So you need to be aware of that. So for example, if your patient suddenly got a fever while on treatment with rituximab, then you need to check if the cause of the fever is an infection. Okay? Now what else? Other drugs that we can give your romiplastim or N-plates. Romiplastim, this stimulates the bone marrow to produce more platelets. Okay? Romiplastim, basically, this is a thrombopoietin receptor agonist, basically stimulating platelet formation. Okay? But you need to take note that romiplastim, since it works on the bone marrow, a common side effect of this would be bone pain. Okay? And your romiplastim can only be given when prednisone fails. It is not part of the first-line management for patients with ITP. Okay? So it can only be as a third or fourth option if certain medications did not work. Okay? General immunosuppressants, they can also inhibit the activity of the immune system. And antibiotics against H. pylori, like clarithromycin, amoxicillin, and metronidazole, this can help increase the platelet count. Now, let's say, for example, your patient with ITP also just happens to have H. pylori, okay, or Helicobacterium pylori, which is a type of stomach infection. Okay. Now, you can only give these antibiotics to help with the platelet count. But if the patient does not have H. pylori, you cannot give these medications and expect that they will have an effect on the platelets. Okay, so they only have an effect if the patient also has H. pylori. Okay? Now, emergency treatment for ITP involves transfusion of concentrated platelets. So there's actually a caveat here, okay? Transfusion of concentrated platelets can only be done for life-threatening complications of ITP. Okay? It is not necessarily a part of standard treatment. Again, the first-line treatment actually for ITP is corticosteroids and IV immunoglobulin. Okay? You only give platelet transfusion during emergencies in order to stabilize the patient's hemodynamics. Okay? So there you go. So in patients with ITP, you will be giving a lot of platelets to this patient. So the risk of that anyway is that this patient could also get a higher risk of this patient has a higher risk of getting hepatitis C. Okay? So your platelets, this is an example of a concentrated blood product. And when you're giving concentrated blood products, the risk for getting hepatitis C from those blood products can also increase. Okay? Lifestyle modifications for ITP. Okay, so what do you need to do if, what does the patient need to do to manage their ITP to prevent any complication? Of course, you need to avoid over-the-counter drugs like aspirin. Okay, certain over-the-counter drugs like ibuprofen, aspirin, they can continue to alter your platelet function. So as much as possible, we ask the patient to avoid those drugs for the meantime. Okay, then we advise the patient to limit their alcohol intake. So the reason for this is that alcohol has a tendency to suppress platelet production in the bone marrow. Okay? Therefore, it will worsen the thrombocytopenia. Aside from that, your alcohol can also irritate the stomach lining and therefore induce a higher risk for bleeding. Okay? There you go. So that's why you limit alcohol intake. Then avoid competitive or high impact activities. So this patient is not allowed to play high impact sports, do high impact training, do let's say do basketball or volleyball. It is best to advise them to do sports that are low impact. Let's say for example, swimming. Okay? So if you're swimming, you have a very low risk of bleeding, okay, in the water because you're not necessarily going to be hitting anything, just the water. Okay? So that's what we can advise our patients. Of course, you need to take note as well of your corticosteroid treatment complications because you will not be giving a low dose of steroids for this patient. It's actually a moderate to high dose just to manage the ITP. Okay? So what could be the complications? So it could cause a cataract, okay, corticosteroids. It could also cause osteoporosis, okay? Corticosteroids actually make our bones more fragile, okay? So osteoporosis. Diabetes is also a higher risk, okay? So the way I teach this to my students, I teach them through the 3 S's, and one of the S's is sugar. If your patient is taking corticosteroids, they will also get a higher blood sugar, causing diabetes, okay? What's the rest of the S? So we have salt, okay? So your patient, if they're taking corticosteroids, they also have a higher risk for salt retention, or they're actually going to retain salt, salt retention. And like we know, no, where salt goes, water follows. So if you have salt retention, therefore you also get water retention. That's why patients with corticosteroids, they tend to look more puffy in the face and they tend to gain weight because of the water retention. Okay? What is the last S? Okay, it's increase of the sex hormone, particularly the male sex hormone. If you're a female taking corticosteroids, it's possible that you will manifest all of a sudden male sexual features. For example, you will get a mustache, okay, or excessive hair growth in the face or in other parts of the body. So those are just some examples. Okay? Other than that, with corticosteroids, this could also cause loss of muscle mass and an increased risk for infection. Corticosteroids basically have an immunosuppressive function. Okay? And that's why it's indicated for patients with ITP. Okay? So that's for ITP. Now we have 5 questions in relation to this topic. It's just a very short discussion so that it's easily digestible for you guys. Okay? So first question that we have, a patient is diagnosed with immune thrombocytopenia. Which laboratory finding is most expected? Is it low platelet count with prolonged PT and APTT? Low platelet count with normal PT and PTT? Normal platelet count with low hemoglobin or elevated platelet count with abnormal WBC. So what would be your answer for this question? What do you expect for a patient with ITP? Very good. The answer is number 2. Low platelet count with normal PT and APTT. Okay? Next, which intervention is the priority for a patient with ITP who has active mucosal bleeding and a platelet count of 5,000 cubic millimeters? Okay, now, this patient with this platelet count has a this patient has a very low platelet count, basically. Our normal platelet count should be around 150,000 to 450,000. And this patient only has 5,000. So, what can you give your patient? Oral iron therapy, platelet transfusion, corticosteroids and IVIG, or vitamin K administration. What will you prioritize to give? Hmm. Okay. I think some people got confused. Okay. Guys, what did we say? Okay. What did we say? The first line treatment, okay, the first line treatment always for ITP would be number 3. It's corticosteroids and IVIG. Okay. Your platelet transfusion, you can only give this in emergency situation where there is already a major complication. Let's say your patient is already having intracranial hemorrhage. Okay, this did not indicate that the patient is having an emergency. The patient just had mucosal bleeding. Okay, that's it. Okay, but it does not constitute an emergency. So this one is number 3. Okay. Third question, a nurse is teaching a patient with chronic ITP. Which statement indicates correct understanding? I should take aspirin for headaches. I will use a soft toothbrush to prevent gum bleeding. I should avoid all physical activity permanently, or I need daily platelet transfusion. So what indicates correct understanding? How do you control the bleeding? This one would be correct. Still number 2. I will use a soft toothbrush to prevent gum bleeding. You cannot take aspirin for this case because aspirin can further cause it can further prolong the bleeding. Okay? I should avoid all physical activity permanently. No, not necessarily. Just avoid high impact sports, okay? Or contact sports. I need daily platelet transfusions. Again, platelet transfusions are only indicated for emergency cases. Okay? Now let's have a select all that apply question. Okay? So a nurse is providing discharge teaching to a patient with immune thrombocytopenia. Which of the following statements made by the patient will need further teaching? So we will be checking the items that are incorrect statements. Okay? Again, you will be checking the incorrect statements in this case. Okay? So let's try number 1. I will use a soft bristled toothbrush when brushing my teeth. Is this an incorrect statement? Yes or no? This is no. Okay? That is not an incorrect statement. Double negative. That is a correct statement. Again, we're looking for incorrect statements. Number 2. I can take ibuprofen if I have a headache. Okay? Do you need further teaching for this patient? This is yes, very good, because ibuprofen is an NSAID, non-steroidal anti-inflammatory drug. It can worsen the bleeding. Okay? I should report any new bruising or tiny red spots on my skin. Okay? Does this need further teaching? This is no. You need to report it. So number 3 is a correct statement. I will avoid contact sports but continue light exercise. This is still a no, correct. Because that's what you will naturally advise your patient. Avoid contact sports, but you can do light exercise. If I have a nosebleed, I will apply firm pressure and wait a few minutes. This one would be, is this correct or no? This is, okay. That does not need further teaching. So, number 6, I should continue taking aspirin daily to prevent clotting problems. Does this patient need further teaching? Yes. Okay, because aspirin can further prolong the bleeding. Okay, very good, everyone. And then for my last question, okay, a patient is admitted with suspected immune thrombocytopenia and a platelet count of 12,000 per cubic millimeters. So obviously 12,000, that's already too low. Then the minimum should be 150,000. So which of the following nursing actions are appropriate? Select all that apply. Number one, assess for signs of intracranial hemorrhage such as headache or confusion. Yes or no? This is a yes. Like we said, intracranial hemorrhage, that is a common complication of ITP. Okay? Administer IM injections to ensure rapid medication absorption. Do you do this one? This is a no, because in patients with ITP who already have a high risk for bleeding, you cannot, as much as possible, give drugs through the parenteral mode because it will cause bleeding. Okay? Monitor for petechiae, purpura, and spontaneous bruising. Yes or no? This is still a yes. Okay? Encourage use of a straight razor for shaving to prevent skin irritation. Yes or no? This is a no. When you use a straight razor, okay, that actually increases the risk for bleeding. Okay? What we advise our patients who have a high risk for bleeding, we advise them to use electric razors, not straight razors. Okay? Implement breathing precautions, soft toothbrush, and avoid NSAIDs. This is a yes, of course. So implement bleeding precautions because there's bleeding risk. And monitor stool and urine for signs of occult bleeding. This is also a yes. So watch for bleeding from the urine and the stool. Okay? So that's it, everyone. That only took up 30 minutes of our time tonight. Okay. So thank you so much, everyone, for attending our short lecture. I enjoyed this very short session that we had, and I hope you were able to learn something from this 30 minutes. Okay. Thank you so much, everyone, and I hope to see you in another session. Thank you, everyone, and have a good rest of the night. Thank you.